Welcome everyone, and thank you for joining us today. This is the first in a series of webinars that we will be holding on the inHEART solution. And today we are joined by inHEART co-founders Professor Pierre Jais, the General Director of the IHU Liryc in Bordeaux, France, and Professor Hubert Cochet, the Head of Cardiac Imaging also at IHU Liryc. They're going to be sharing their insights with their firsthand experience with the inHEART platform and answering questions from physicians. So welcome, Professor Jais and Professor Cochet, and thank you for your time today.
Thank you.
Hi, Jody.
Hi.
Thank you.
And my name is Jody Lamberti, and I will be moderating today's conversation along with my colleague, Katie Arnold. And we'd like to begin today with a brief overview of the inHEART solution. We'd like to hear a little bit about how it came to be and how you're using it to change the way you treat arrhythmia patients. So Hubert, would you like to take this one first?
Yeah, with pleasure. The inHEART story begins as a research project 12 years ago. So I'm a radiologist working with cardiac imaging, and at that time I was doing a PhD on the structural substrate behind cardiac arrhythmias. And so I met Pierre 12 years ago, and I entered his lab, and the first thing I noticed is that it was a mess. The data he was working with seemed to me, an outsider, very complex. But at the same time, I saw that he was using a 3D catheter localization technology, and this made it possible to localize his signals and the origins of the arrhythmias in my images. So this is what launched what was originally a research program where we were correlating electrophysiological findings with characteristics of the myocardial tissue on MRI or on CT as acquired prior to the interventions. So this was a research project for the first years, and we soon learned critical areas in the image that were matching the critical isthmuses of VT. And we started integrating this in our therapeutic approach. So at first, when we were communicating this in scientific meetings, everyone was saying, okay, these are the nice images from Bordeaux, but how can I get that in my lab? So very soon we launched an academic program where people could send their images and we would send back 3D models. And it soon got out of hand beyond the reach of a research program because a lot of centers were willing to join. So in 2017, we had the idea to launch inHEART as a company in order to provide this as a service, knowing that this expertise can travel because images can travel, but patients cannot. So this was the idea that we got. And I think it changed a bit the way electrophysiologists approach these arrhythmias, right, Pierre?
Oh, completely, yes. It's been a game changer to meet you, Hubert, and to meet, in fact, cardiac imaging for me. I can maybe, before you launch the videos, explain a little bit how it was perceived on my side as, well, finally, the end user of what we have created together with inHEART and the academic program you mentioned. You know, I'm a cardiologist. I'm specialized in electrophysiology, and I know nothing about cardiac imaging. I mean, I can understand that there is a lot of information that could be useful for me treating patients, but I have no access because I'm not really an expert in slice images, and I'm not keen to become a second Hubert or a radiologist. So I thought it would be much easier for me to get some 3D reconstructions that would display really accurately the anatomy of my patient with the substrate in it. And so that was what we've been working on and what inHEART is delivering now. And so if you want to show the images, we may go through what it really delivers. So we have, you know, the left part of the slide, which you know, where we do the classical EP mapping, where we have access to the substrate, but in 2D, it's only what is in contact with the electrodes that can be described by mapping. And if you think about the third dimension, the thickness of the LV, because it's often in the LV that the arrhythmia comes from, it's much less accurate. In fact, we have pretty much no idea. I was struck by this demonstration by the group of Katja Zippenfeld, where they showed that if you have only 2 millimeters of healthy tissue between your electrode and the scar, you miss the scar. So it's very limited. And it breaks my heart to admit it, because I've been devoting my entire life to better understand and read those electrograms. This is really what I'm good at, and we've been working a lot on that. But I must admit that there are additional information in those images that are really useful for us to take care of those patients. And to me, this experience was like, if all of a sudden we were switching on the light in a dark room, you know, we were doing these ablations in a dark room, and now we have access to much more details. And this is shown on the right side, a part of the slide where you have the scar that is so nicely described by these images. You get that before the ablation, so you have a chance to look at it before you get to the lab. You have a chance to discuss those with your patient, and you have a chance to discuss this with your colleagues to define what the ablation strategy will be. And this has been really useful. And I don't know if you want to comment on the correlation we observed, because this is of course important between the electrograms and the images. We've been working a lot on that.
Yeah, it's been in fact the origin of the project, where we were seeing abnormal features in the images, and we were willing to compare that with electro or EP findings. So we've been extensively correlating scar transmurality from MR with voltage, wall thinning from CT with voltage, with late potentials or fractionated electrograms mapped during sinus rhythm. And what was really something that gave us an even more precise or higher level of proof was when the high density mapping system came on the market. So these arrhythmia systems, for instance, that were for the first time allowing us to map the scar with a lot of details. So we've been relating our imaging findings with these high density maps, demonstrating that some features in the images, and particularly on CT scan, channels or corridors of relatively preserved thickness, this is a color coding of the thickness, within severely thin infarcts, were hosting critical isthmuses of ventricular tachycardia. And this was for us a proof that was much stronger than any electrogram findings in sinus rhythm. I think you would agree with that, Pierre.
Yeah, definitely. You might come back to that slide, because it's important to understand that cardiac imaging, when it comes to ventricular tachycardia at least, has been really all about MRI. And MRI is a fantastic modality, but the spatial resolution is not so good. And it's much higher with CT scan. And so at some point of time, we sat down with Hubert and said, look, maybe we should investigate what CT scan can do on the ventricular substrate for ventricular tachycardia. And this is a complete surprise. We had no idea that CT scan could describe so nicely the myocardial scar. At least I had no idea. And more importantly, it shows a very heterogeneous distribution of the wall thickness in the scar. And so what you see in dark red, as Hubert said, is an area of extreme thinning, meaning that there is almost only fibrosis here from the infarction, from the injury. And these red areas act as barriers for the propagation of the impulse in the scar. It's not to say that you will never find any electrical activity there. Well, you always have far-field electrograms that you may encounter in these areas, but you may also have lava or isolated potential, as some of us call them. And these potentials are typically very delayed in the red scar, the dense scar, because there is not much surviving bundles here. And I think they don't even actively participate in the circuit of the tachycardia because their conduction properties do not allow for that. Rather, you would expect to have, in fact, the isthmus matching this city channel where the wall thickness is more to the 2-4 millimeters range. This is where you have a combination of fibrosis and surviving bundles that is the path for the reentrant VT circuit in the scar. And this is nicely demonstrated in this example. It's not just about arrhythmia. Cato catched up and Site recently catched up. And we have had demonstrations with all three systems. It doesn't matter which one you use, that in fact, those city channels were very nicely matching the VT isthmuses when we were able to induce the tachycardia, which is not always possible, and when the tachycardia was hemodynamically tolerated, which is not always there either. But when it was, it was a very good match. Now, we see more city channels than VT isthmuses, but this is probably partly due to the limitations we have when it comes to mapping VT. Again, they have to be inducible and they have to be stable so that we can map them. So it's not a surprise that we have more city channels. And I think that this type of reconstruction and images provides, in fact, a more comprehensive information about the substrate for VT, including those VT that we cannot induce or map.
Good. Well, thank you for that, Hubert and Pierre. This, it's really exciting to see you bringing that additional substrate information into the picture with your ablation strategies. So what I'd like to transition into now are some of the specific questions that we have from physicians. And your last topic, Pierre, is a nice segue into this one, as we're working toward talking about these ablation and treatment strategies. Specifically, when you're ablating the VT channels for ischemic VT, how do you construct an ablation strategy using the inHEART images?
Yeah, that's a very important question, and there are several aspects to it. The first important step is that we have to register the reconstructed images from CT or MRI, whatever modality you use at that time, with the coordinates in the Cato, arrhythmia, insight system, whatever. So we've been investigating that quite a lot, because it's not a trivial issue. You have to have a registration you trust so that you can really be accurate when delivering the lesions. And if you go retro-aortic, then fast mapping the aorta with, for example, the ablation catheter is a very good option. It's much better than trying to register on the atria for reasons that Hubert can explain further. I don't know, you may want to do that now, Hubert, and then I'll get to the
yeah, if you will, because this is a mistake that we've made, and that some of our colleagues have made also, because registering on the atria works for AFib procedures because the imaging is done during end ventricular systole when the atria are at their maximum size. So the anatomical geometries of the atria match well with the CT scan. In ventricular cases, it's the other way around. We are imaging the heart at ventricular diastole, and at that phase, it's usually immediately before the P wave. The atria can be half their maximum volume, particularly in patients that have normal filling pressures. So you would end up with non-matching volume. So the best way to go is indeed the great vessels. So aorta or pulmonary artery, right, Pierre, when you go transeptal?
That's exactly right. So if you choose for whatever reason to go transeptal, and we often do, because in those patients with myocardial infarction, you may have plaques in the aorta, and you don't want anything to migrate, of course. So we often get a transeptal approach, and then we would fast map the pulmonary artery and the two main branches, right pulmonary artery, left pulmonary artery. This also proved quite effective. And you can also fast map the coronary sinus, for example. Again, this takes a few minutes, typically 5 to 10 minutes. And then we perform that registration. We would then take the ablation catheter, which is magnetically navigated in every system, and go to the apex of the LV just to have a further trust into the quality of the registration. Of course, if your catheter is 5 centimeters out of the reconstructed LV, there's something wrong. It usually doesn't happen. But so once you have confidence in your registration, then you can have a look to the models and define your ablation strategy. Again, this can be done before the ablation. It can even be discussed with the patient, because you have typically the images done before ablation as per the international recommendations. And then what you see here coming in and out is our understanding of the substrate. So the plain white lines are contouring the areas of barriers where the electrical propagation is almost not possible. In between them, in green, you have the CT channels. And again, we did not anticipate that, but this matches very nicely with VT isthmuses. And so this is defining our targets. We would aim at interrupting these potential isthmuses for VT in the scar. The other very interesting information that is provided by the CT scan is that not only you visualize those isthmuses, but you also are able to identify the area where the thickness in the isthmus is the smallest. And this is interesting because we have learned by matching, imaging and some recording, particularly epicardial recording, whatever, we have learned that RF can do a good job and up to 4 or 5 millimeters in depth. And so this is important information. And it means that you would rather ablate the CT channel where the wall thickness is no more than 3-4 millimeters, so that you have transmural lesions that are more likely to be durable. And this may be potentially a good way to reduce the amount of recurrences we may have after ablation. So this is what is shown here. And that's important because we've made the mistake a couple of years ago to try to block the entrance and exit rather than these more vulnerable areas in the CT channels. So do not do that as we did, and take advantage of what we learned. Go for the easiest and lowest hanging fruits. So that's quite a lot of information in those images, right, Hubert?
Yeah, definitely. Definitely. One thing what should be mentioned here is that this thickness analysis is particularly suited to post-MI VT. It works in almost every post-MI VT because these patients usually have very old infarcts. And these infarcts remodel through time, and this remodeling induces thinning that is heterogeneous. And the reason why we have to wait 10 years is that this scar has to mature before being prone to re-entry. And this is what CT maps very nicely. In non-ischemic diseases, maybe we'll get to there later, but it not always work, except for one particular subset of patients, which are the ones who have old chronically remodeled myocarditis that are associated with severe thinning and that can be interpreted as we interpret ischemic VTs, and potentially also amenable to endocardial ablation because the wall is so thin that even though the scar is predominantly subepicardial in myocarditis, it can be accessible from the endocardium. But for other non-ischemic VTs, we probably will get that later. It's probably other strategies that have to be implemented.
Hubert, I think the right part of that slide was showing something interesting, which is a reaffirmation.
Sorry.
I don't know if you want to comment that, but clearly it looks a bit primitive, those white arrows on the right reconstruction, where you see the ablation catheter with the force displayed. And these are drawn directly in the navigation system, right? So
yes, so this has changed, obviously. This is a case illustrating what we were doing several months ago, where we had to annotate this in Carto. But now in the inHEART platform, there are multiple tools for the clients to be able to annotate the model, drawing lines, distributing ablation points, and all this can be exported in Carto and Sight, Navix, and other 3D mapping systems.
thank you.
So kind of along those lines, do you use additional EP study data and electroanatomical data to finalize the strategy?
Yeah, this is very important. This is how we started, because at the beginning of it, we had no idea that imaging could provide so rich information. So the first step was this correlation with electrical activity. And then we had a hybrid approach, which is still used by some centers a lot, in fact, many centers, where they take advantage of knowing where the substrate is, and then they map more specifically and they focus on that area of the heart. And so they save time by doing so, but they keep mapping as they used to, and as they would without image integration. Now, we did that for quite some time, and we no longer do it. We, as cases were going, we thought, look, maybe we could just directly go to the spot as indicated by the images and deliver energy there. And we went as far as no longer using any dedicated mapping catheter. So the latest version of this approach, which is a bit provocative, is just using 2 catheters. We typically have one diagnostic reference catheter and the ablation navigated catheter in the navigation system. We just fast map the aorta or the pulmonary arteries and then go straight to the CT channels and ablate. And by doing so, we save a lot of time, of course, and some money as well, because we do not use this mapping catheter. I'm not saying that this is the only approach or the one that people should choose, but it exists and it provides interesting results.
Can you, Pierre, elaborate a bit? So you showed us in the previous slide how you were blocking these channels. So a line of ablation that transects the channel. Can you tell us, and you were also showing us where you would put that line along the channel on the thinnest area in order to be transmural. Can you tell us what's your local endpoint? Because I
Yes.
believe that these cannot be blocked.
Yes, that's very important. It would be quite tedious to demonstrate block on each of the CT channels, and definitely would require extra catheters. So this is not the approach we've been following. Rather, we look at electrograms where we transect the isthmus, and it's a good thing when we no longer see any lava abnormal potentials, but this is not always possible because it's just one line and you get far field activity even from the lava that are adjacent, because it's important to understand that this approach is quite different to the lava elimination. We leave plenty of lava. We just block what we think is going to be responsible for the VT. And so the simplest and yet quite robust endpoint we ended up with is just to pace with the ablation catheter the standard loss of capture with 10 milliamps and 2 milliseconds pacing strength. And we're happy when we lose that capture. Again, this is probably more meaningful in really thin areas where you just have 3 millimeters wall thickness as compared to what you have in healthy myocardium, I think. And, you know, it has been quite successful. And then we have a more global endpoint, which is non-inducibility, of course. This one has been there forever.
Yeah, but it's very important, this non-inducibility thing, because this is very reassuring with respect to the efficacy of the procedure, because our experience has been that, you know, by doing so, the majority of patients are non-inducible and you are out of the lab in less than 2 hours for a VT ablation. So it's almost as fast as a PVI, very, very close to being as fast as a PVI for AFib. But if there's something that remains inducible, you convert to the pace mapping and trend mapping strategy, and you chase these remaining VTs that are usually super fast and maybe different. But what I'm saying is that the endpoint being the same, it's a win-win, because even if you have still inducible VTs, you will gain hours of procedures by doing so, with no risk, and the same EP endpoints. That's important for the final endpoint.
Absolutely. And in addition to that aspect, I think one of the things I have been considering very important during my entire career is that we have to make it as easy as possible for the patient. And this means that if we can work in sinus rhythm, if we can stay away from general anesthesia, from hemodynamic support, etc., we are probably doing a better job for our patients. They will recover faster, have a better experience. And this approach is really suited for that goal, where we don't even try to induce before starting the ablation. So we would straight go to the point, devote really the time in the lab to ablation, which is what cures patients or what improves patients, rather than trying to understand the substrate mechanisms, etc. All this part is taken care about by imaging and is defined before getting to the lab. So in the lab, it's really about treating the patient quickly, efficiently, and with the least amount of stress as possible. So yes, you're right. If patients are inducible at the end, we would convert to a more conventional approach if we think that what is inducible does not use the CT channels. And we have to check that. It's important. And in 20% of those cases, it's in fact insufficiently ablated channels or reconnected channels that we have to take care. And if it's not that mechanism, then we also learned a lot from images, because we have another type of VTs that might be inducible after we took care of the CT channels. And these are typically faster, may not be that sustained, may be polymorphic, and typically use the substrate in the periphery of the scar, where the transition from dense scar to healthy myocardium is very smooth and take 2 to 3 centimeters. This seems quite characteristic. Yeah, exactly. That's the area Hubert is pointing out at now. And when you have a very abrupt transition between the dense scar and the healthy myocardium, you don't see those arrhythmia. So that's also one of the benefits of using images.
So Pierre, you touched a bit on the correlation between the substrate information and the electrical anatomical information just now, but how are you confident that you're ablating in the correct areas? Kind of specifically, what is that specific correlation between the wall thinning, then the scar with the voltage and activation mapping with those 3D electroanatomical mapping systems and the 2D recording systems?
Yeah, this is really important. And so, this has been our first obsession. We wanted to understand if we could trust those images and what was their meaning with respect to what we know, which is electrograms. And it turned out to be very good, with the limitation that you have to have a very good registration. This is super important. This is why we started this discussion earlier. And so if you can trust your registration, then you will typically find what we found. And it's interesting because I think 95% of the groups using this technology are repeating what we did a few years ago, and they map, and then they email us and they say, it's fantastic, it's a perfect match. And you say, well, yeah, well, this is not a surprise, but it's good that you get convinced about that.
And even Pierre, there's also one interesting thing is that we discovered that between two different separate groups at the same time. I remember that at that time, you were more doing lava ablation, and when high density mapping was coming in, VT mapping in these patients, while Frank Bogan at Ann Arbor was with his ablation catheter only doing extensive pace mapping and entrainment mapping maneuvers, inducing 8 to 10 VTs per patient during 8 hours long procedures. And he found exactly the same thing, that he called this not channels but ridges, CT ridges within the infarct. And this is now something I think important in his strategy to direct his pace mapping strategy directly to the right spot. So that's interesting that the different, and again, it was not expected by us or by anyone. That was kind of a surprise.
Absolutely. And generally speaking, I don't think we're smart, and I trust more unexpected results than expected results.
And there's also one very important thing. It's that as compared to MR, the link is so strong between CT thickness channels and VT in post-infarction. We're talking about chronic post-infarction VT. That even with a good MRI, even with a high-res MRI, the best resolution you can get clinically today, it's not as good as a CT. And CT is more available because there's a problem of spatial resolution in MR that makes us, that prevents us from analyzing these gray zone channels within dense scar, because that's what MRI does. It's not thickness, it's gray zone within more dense scar on late enhanced images. And in these chronic infarcts, when the thickness is as low as 1 to 2 millimeters, this exceeds the size of an MR pixel. And on MR, we know very well, we radiologists, imagers, that you need to put 2 pixels within the wall to have an accurate intensity within this wall. Otherwise, you have what we call partial volume averaging, and this makes a white pixel into gray. So there's really more information in CT for post-infarction VT, and we are really confident in that right now. It's a different story for the non-ischemics, of course. We'll get to that maybe later.
Even 2 pixels, I'm not sure it's really enough, because they may still, be overlapping with some blood flow, blood pool, or extra cardiac areas. Yeah, this is a big deal, and even in post-MI VT patients with no ICDs, which is rare, I prefer working with a CT scan if I have to choose between the two modalities. And we may have time for that later today, but MRI is a fantastic modality for non-ischemic, but for ischemic, I guess 95% of them, I think, are better described by the CT scan, which was, 10 years ago, it was completely unexpected. No one had any idea of a potential role for CT scan in this context.
But it's specific for VT, because for acute MI, obviously MRI is much
that's different.
We've had a question come in on this topic. What is the turnaround time then for getting service, the inHEART analysis, once you've sent in the CT or MRI scan? Maybe Hubert, you can speak to that.
Yeah, so by contract, it's 1 working day. But in fact, it depends a bit, or we can be much faster than that. And this depends on the location, because the data is processed in Bordeaux. Our algorithms and expert case analysts are based in Bordeaux. So when you're US based, you're kind of lucky, because you can submit a scan late in an evening, and then our team is working while you're sleeping. And at breakfast, you receive the model with a mail indicating. You click on a link, and then you can visualize your model while eating your cereals, and then it's ready.
And,
so,
and Hubert, what about patients with electric storms?
We've been assisting cases with electric storms remotely, distantly, not only in Bordeaux but elsewhere in the US, with turnaround times below 2 hours. So yeah.
So
this is something that is really a strength of this service model, because I think that beyond maybe some ultra expert centers who may have someone in the EP department willing to do this segmentation, this is not doable elsewhere, because in any case, the radiologist won't do that. I'm a radiologist. I'm not the slave of the EP. I'm not the one who will segment. I'm doing diagnosis. This is my job. I'm not the one who will build a 3D model taking time segmenting data. That's not the job of a radiologist. So this is very complex to implement in real life, and having a personnel that is trained on site to do this and that has the time to do this, I'm not sure it's even cost effective. So yeah, this is why we opted for the service model, and this can be then launched instantly in any site.
good. So another question that we have is, with the latest advances in 3D electroanatomical systems, ischemic VT ablations have become somewhat standardized and are considerably less difficult than in years past. So how is inHEART additionally helpful in these cases?
Yeah, I think that ventricular tachycardia ablation is still considered by some EP doctors in some centers as complex procedure, and honestly, they're right. It is a complex procedure, and also a procedure that is associated with potentially more complications than a more standard, let's say, ablation procedure. And even proximal AF ablation is considered way simpler than VT ablation. Now, I think that when it comes to post-MI VT, it can be relatively simple. Not to say that nothing may happen. Of course, complications can always happen. But the process we just described earlier today where you just register your images, you have a really accurate description of the substrate, you get there, do your ablation, and you're done within 2 hours. It's a really significant simplification of the procedure. It makes it also much more efficient for the lab occupancy. You know that it's going to be a 2 hours procedure. We have the exact value is 110 minutes plus minus 25 minutes. So it's a very narrow standard deviation, which makes the duration predictable, and that's important for centers who want to optimize their lab time, and they know how much time it will take, and that's quite new in the world of VT ablation. I also think that this should translate into a superior safety, because shorter procedures typically are associated with better safety. And so I'm not going here to say that it becomes as simple as paroxysmal AF ablation, which is not always simple, but is simpler. It's not to that point, but we're getting closer to that as compared to what we used to do in the early days, where we were spending hours inducing VT and mapping VT and having drops in the blood pressure. And you know, even if it's not 5 systolic blood pressure we're talking about, even if it's 8, it's not good for the patient. If the patient is used to 12, it's not the same. And I think it's not completely trivial, particularly in elderly patients, where the kidney is going to suffer from that, etc. And so the patient experience and the recovery is clearly improved by these short VT ablation procedures.
Good. Thank you, Pierre. So, and Hubert, you were kind of mentioning this a little bit in some of your responses, kind of discussing or hinting toward talking about the workflow of non-ischemic cases. So can you tell us a little bit about what your workflow is for these types of?
So in non-ischemics, imaging is even more important because it starts with diagnosis. Which non-ischemic cardiomyopathy? There are dozens of these, and imaging can provide an accurate diagnosis. For instance, this is probably not related to catheter ablation, but when you have a diagnosis of cardiac sarcoid with edema and inflammation, maybe catheter ablation is not the good way to go, and you should rather use drugs. So there's a huge impact of imaging on describing what's the cause. And then once the cause has been identified, there's also a huge impact of imaging to describe what's the distribution of these scars, because it's much less stereotyped than in infarcts, and because it's very often undetectable with any catheters, because these scars can be located in the intramural layers of the myocardium. There's no way any catheter can see that, or subepicardially located close to the LV summits. And even if you're mapping from the epicardium, you won't see that because the thickness of the fat in the epicardial space is too high for you to be able to detect any abnormalities there. So it's really finding hidden substrate, and then obviously then going faster there and applying the appropriate route to get there. That's important. And potentially sometimes also deciding on what's the optimal energy to reach it. This is a huge impact of imaging. So I don't know if you agree, Pierre, but I think there's a huge impact on efficiency as always, because you go to the right spot faster, but also I'm expecting, but this is very complicated because performing randomized controlled trials on non-ischemics, first, they are more rare than ischemics, yeah. Plus it's so heterogeneous that it's impossible to match. But anyway, it's obvious that you see the target, and so you're probably more prone to reach it when you see it.
Absolutely.
So you think, yeah?
Oh, absolutely. The worst case scenario here in non-ischemic is when you have no imaging to guide you, because there are not infrequent situations where the patient is having VT, may receive shocks, and you have no idea of what the substrate is because you don't really map it with catheters, and you may not be able to induce the VT, or it may not be tolerated, and you have no clues. So you can use the 12-lead morphology and try to do some pace mapping to reproduce that. It's quite limited. In those patients in whom you cannot map the VT properly, then imaging becomes absolutely critical. And as you said, Hubert, it even allows you to decide whether you're going to go epicardial or not, and you know that in advance. You can refine your strategy, and so it's really a game changer here.
I think it's important to understand how or the broad spectrum of options that you guys have to access the substrate. You know, you can go from the RV endocardium, so the right side of the septum, the LV endocardium, but you can also go from the CS, and sometimes you can even go via perforating branches of the CS in the septum when it's deep substrates. Some are also doing ethanol infusion, either in the veins or in the arteries, and all that imaging can show you. We can map where the arteries are. We can map where the CS branches are. We can analyze how deep is the substrate. For instance, this case, Pierre, can you tell this story?
Yeah, that I was very impressed with this patient. He is almost 80 years old, known for a non-ischemic cardiomyopathy. He's been implanted with an ICD. You can see the artifact on the CT images here. And so, you know, he was flying back from the French Antilles and started to receive ICD shocks while flying. So there was a bit of emotion in the plane, of course, you can imagine. And so they landed in Paris, and then he went to a reanimation area in Paris, and they had to put it under general anesthesia, intubated, ventilated, because there was no way they could control the arrhythmic storm. And so he finally was transferred to us in Bordeaux. So he was still intubated, ventilated at the time. So we did some imaging. Of course, he was having an ICD. Not to say that MRI is not possible in patients with ICD. It is possible. It's not a safety concern. It's a quality of image concern. So those ICD, they are MRI proof, but they kill basically the images. We did some late enhanced CT, which is similar to the light guide for the MRI, same concept. And it shows what is considered by EP doctors as a nightmare, a very large.
Maybe I can comment on this image a bit.
Yes,
So what you see on the left is the arterial enhanced CT. So it's the same thing as a coronary CTA. So it's when you inject the contrast, the first pass of the iodine through the heart gives you this image. So this is a fantastic image to map the anatomy, measure the thickness of the ventricular wall. We saw that in ischemics, also map the arteries and stuff. You can also map fat, particularly in the right ventricle for ARVC. So it's a very interesting method, not only for anatomy, but also for certain substrates. But for fibrotic scars that are located in areas that are in areas of preserved thickness, you don't see that on arterial enhanced CT. For that, you need late enhanced CT, which is the similar thing as late enhanced MR, except that it's done with iodine and not with gadolinium, and that it's a bit more noisy. It's better spatial resolution, but a bit more noisy. Of course, if you don't have an ICD, it's better to do that on MR. You have a better contrast, but still you can see that. And this patient, in fact, we managed to get his old MR performed 10 years before prior to ICD implant, and you see that the substrate didn't move much. It's almost transmural there, but in other areas, it's intramural, maybe 2 millimeters depth, and the thickness here is probably greater than 1 centimeter. So there's no way you can achieve transmural ablation with RF from either side of the septum here. Maybe here, but here or there, it's impossible.
Yeah,
so Pierre, how did you manage the patient? This is
maybe you just get back a second on the previous slide, because again, this is really a nightmare. You know that if you ablate from one side, then the blood pool on the other side will act as a heat sink, and you will never be transmural. And it works, it's symmetrical, of course. So these septal VTs are really complicated to deal with, particularly if you have a big substrate, and here it's huge. So I really was anxious, and when I saw the images, and you can move to the other one, really, so see how big this is. We made the decision to straight go for bipolar ablation. So we've been using for this case a Carto system with some smart touch ablation catheters. You can see the contact force, 6 grams on the right side. And I think it was the way to go. Again, the patient was dying from storm. He was intubated, ventilated, quite dramatic context, and pretty old, some kidney failure, etc. It was really a difficult situation, and I wanted to give him the highest chance of success for a single procedure, if possible. And we did the ablation with 2 catheters, one in the RV, one in the LV. You see on the right part of the slide, it's just showing the scar area, which is massive in septum, and we took the decision to create 2 ablation lines that would transect the scar. We had no idea really where the arrhythmia were coming from, because it was several monomorphic morphologies. We even had some polymorphic VT in this patient that were recorded, and you see the X-rays on the superior part showing you the 2 catheters, the 2 ablation catheters. This is not visible in the Carto system. You have to have a dedicated research toolkit that we don't have access to see the 2 catheters in 3D navigated. So we just saw the LV catheter, which was to monitor the LV catheter, and we placed the RV catheter facing it, with multiple angle fluoroscopy. You can do a good job at making sure that they are really close each other. And there has been very clear demonstration that this type of bipolar ablation is way superior to unipolar, sequential unipolar, or synchronous unipolar deliveries. So I think Hubert mentioned that the wall
superior in terms of damage, right?
Yeah, exactly. Yeah. Well,
it's a relative judgment. Yeah, here you needed something that's very powerful.
Yeah, that's very sad. It's the only way we have to treat patients. It would be much better to restore function, but we're not there yet. So we thought that we would be more effective with ablation by choosing bipolar, including in those areas where, well, this patient has a preserved wall thickness, meaning a centimeter to target, which is out of reach for the conventional RF. And there were some basal areas in the septum that were even superior to 1 centimeter. So really, thanks to imaging, we knew that it probably was the only way. And I was very impressed by this patient, because it's been 6 months now, and he had 0 arrhythmia in the logs of his device since the ablation. So it's a great success, which I feel I should attribute to Hubert and images, because it was a game changer for this patient.
You mean to inHEART?
Yeah. Thanks.
Thank you. Yeah, thank you for that. And yeah, quite a dynamic situation that you described there with that patient. So I have one more question for you, and then it's been such a great conversation this morning. We're not even going to get to some of our other questions we had planned today. So we'll save those for the next webinar series. But the last question for today is, what are the limitations of the inHEART technology, and how do you optimize your workflow for those limitations?
Well, shall I? Yeah.
Yes, please.
Yeah. So I think one limitation is the need to perform pre-procedural imaging if it's not in your workflow. For sure, this is something that has to be done, but most of it can be implemented from CT, and CT is widely available. So this is doable. And in ischemics, arterial CT does the job. So it's, I think it's possible to implement that everywhere, and the short turnaround time makes it doable even in storm patients. Now for non-ischemics, that's true. There's a limitation in centers that are not experienced with acquiring MRI in patients with ICDs or doing late iodine on CT. But for that, at inHEART, we are the service model allows us to get a feedback on the image quality and to train the sites and to share protocols between sites or connect different sites that have the same CT scanner or the same MR scanner, and we usually manage to implement the appropriate tools everywhere. So yeah, I don't think, and then so this is the workflow limitation of inHEART, and then the probably intra-procedural limitation of inHEART remains the registration. So Pierre showed you how accurate it can be. And really, if you're cautious in doing that well, you can trust the registration. But yeah, we're still looking for tools to have this automated in these EP mapping systems, but we're sure it will come shortly. There's no technological obstacles to it.
In fact, one of the ways we've been doing the registration in the early days was by using the substrate in post-MI VTs. And this is a nice way to do it, but you're losing quite some time for something that is already available. Because if you can register based on the substrate, it means that it's a very good match. So just register with the aorta or the pulmonary arteries and you're done. Just one additional word when it comes to those limitations, particularly the imaging that has to be done before the ablation. This is in the international recommendations anyway, because it has been identified as something needed, helpful, and that could reduce recurrences. So it's pretty clear that every VT patient should get that done. There are plenty of benefits, even without considering inHEART. This is really something important to do because the diagnosis is impacted in plenty of things. So no modern VT ablation without imaging. That's really what I think.
Great. Well, Pierre and Hubert, it's been wonderful speaking with you today. And we want to thank you again for your time. And like I mentioned before, we still have many more questions and we will save those for our next webinar. And so thank you to attendees for joining us. And if you have additional questions, please feel free to reach out. You can reach out at the sales@inheart.fr email. And like I mentioned, we'll have another webinar coming in January, and more information on that will be coming out soon. So everyone, have a happy holiday season, and we look forward to connecting with you in the new year.